Good morning, friends, and I thank the organizers for inviting me to chair this session on enzobiotics in CKD. Uh, Sanjay needs no introduction on this topic, but Sanjay is from Bangalore, and I can take credit for saying that I inspired him to take nephrology, work with me initially, then joined Dr. Mani and got trained there. Gut and the kidney is very important. Gut-kidney axis, everybody talks about it. And I remember listening to Professor Muthu Sethupathi on gut and microbiome, telling us that there are more than 100 trillion bacteria in our gut. And they have an axis not only to the kidney, to the brain. That's why you use the term gut instinct, gut feeling. Even though we nephrologists still use the term gut feeling when we treat transplant rejections. I know it's not evidence-based, but still many of us go by gut feeling. Talking about this topic, I think at this juncture, I would like to pay homage to Anita Saxena, our dear colleague, Dr. Amit's wife, who's done a lot of work on this topic. And Sanjay is going to present one of the publications made by her, along with Dr. Chako and him. And so I pay homage to Anita, and I request Sanjay to go on with the topic. Thank you, Sanjay.
Thank you. Good morning to one and all. And I'm very grateful to the organizers, both the scientific committee, for having given me a chance today to speak on this EETOX study. The EETOX stands for, enzobiotic for elimination of toxins. Now, the concept of enzobiotic means where we are using an enzyme with a probiotic. Now, the concept has first time come out in India. It is started from India. No other group has thought about it. Now, if you can see, the EETOX study has its place in Coimbatore also. You see, Dr. Ilangavan Veerappan from KG Hospital was one of our investigators. So as sir said, Dr. Anita was involved, so due remembrance to her because she was instrumental in the study and was also helpful in publishing it in the journal. So the outline of the talk is, basically I'll be talking on dysbiosis in CKD and how it causes progression of CKD, the defects in protein metabolism, the role of protein-bound uremic toxins, then we come to symbiotics, the journey to enzobiotics, and EETOX study of ours and what were the findings. Now, if you look at the pathophysiology of CKD and CKD progression, two factors seems to play a very important role. We know about it, but we don't give much concentration to it. One is the dysbiosis that happens in CKD and the improper protein breakdown. We do restrict the protein intake in our patients, but we don't do much about it. Now, if you look at the three arms of management of CKD, we do great as far as the hemodynamic control is concerned. We do great from the metabolic control as concerned to retard the progression. But we know very well, one of the factors which leads to the progression of the disease is the inflammation and the fibrosis. What do we do about it? There is nothing much that we are doing as of now. So now dysbiosis and improper protein breakdown probably plays at this level and induces inflammation and fibrosis leading to the progression of the disease. Now, if you look at the human gut, there are more than 100 trillion microbes which behave themselves as an endogenous organ. They maintain the integrity of the gut and they play important role in the maturation of the immune system. They play important role in maintaining the intestinal epithelial barrier and also the sheer volume of the organisms that are there. They become competitor for antimicrobials, other antimicrobials, thus preventing the infection. Now, this is how the harmony is maintained. If the harmony is maintained, the gut is maintained normal, the epithelial barrier is maintained, and everything goes on fine. But once the CKD sets in, the dysbiosis starts. That is, the eubiotic state is replaced by a dysbiotic gut, which may be because of the high urea level causing ammonia accumulation, decreased consumption of dietary fiber, which we restrict in these patients, slow colonic pursuit, antibiotic use, and whatnot. Whatever we do adds to dysbiosis. Now, if you look at when the humans came onto the earth, they were the gatherers. They used to have more of plant-based diet. And this plant-based diet means that there is more fiber into it. More fiber means there is a fast transit from the stomach into the small intestine, from the small intestine into the large intestine. But unfortunately, there was a problem there in the sense that there was no freedom for easy evacuation of the contents, that is a bowel evacuation. That is because of the dangers that were involved. They were living in a dangerous environment. So this leads to more and more accumulation. That's why the colon or the large intestine became large. And now because the fiber content was so much, it got accumulated with large number of bacteria which are supportive. And to an extent that they use these bacteria caused more release of energy from the fiber which was there, to an extent that you are getting almost 5% of the daily energy need of the human from the colon. But what happens when there is dysbiosis? It leads to change in the alteration in the normal flora that is present. There is increase in the aerobic and anaerobic organisms in duodenum, jejunum. There is increase in the volume of the organisms that are there, though from stomach up to the colon. There is a decrease in bifidobacteria, which is protective for the epithelium. So what do we see? This leads to loss of the barrier function. Multiple factors are there. Villus height is reduced. There is elongation of the crypts. Then there is tight junction proteins which are lost. So indirectly it leads to translocation of the bacteria and causes microinflammation. So this is what sets in. So there is a disruption of the epithelium. There is a percolation of the endotoxins. There is percolation of the organisms, and it induces the inflammation. This is as far as the dysbiosis is there. So what happens when there is an impaired protein metabolism? So, and causes for that. The causes are the same as dysbiosis. I told you that they are more interdependent and interchangeable. So once there is an impaired protein metabolism, there is increase in the peptides in the colons. Through tyrosine and tryptophan pathway, it leads to increase in the p-cresol levels. There is an increase in the indole levels, and which in the liver gets converted into p-cresyl sulfate and indoxyl sulfate, and which in turn leads to higher levels, leads to endothelial damage, the inflammation, which will affect almost every organ in the body, causing uncontrolled hypertension, CKD progression, increased cardiovascular morbidity and mortality, and it also induces insulin resistance and impaired glucose metabolism. So basically what we are saying is there is a good cocktail for high inflammatory status and behaves like a metabolic syndrome also. So do we have any evidence of the same, that these protein-bound uremic toxins causes all these problems? Yes, there was a paper which came out by Wu et al. And they looked at role of p-cresol sulfate and indoxyl sulfate and how does it induce these problems. And it is known that it induces the oxidative stress by activating the NADPH oxidase, and there is a direct association of the indoxyl sulfate for aortic calcification and vascular stiffness. Now the endothelial damage is common for both. In the end, what it leads to is an increased overall mortality as well as the cardiovascular mortality. So this is the whole pathophysiology what we are saying because of dysbiosis as well as the protein metabolism, improper protein metabolism. So it behaves with increase in the inflammation, the increased toxins leading to increased CKD, and there is an increase in the CVD, and there is a formation of an environment which behaves like a metabolic syndrome. So next comes whether the probiotics are useful. Now if you look at probiotics, usually they are combined with prebiotics. Prebiotics are the chemicals which potentiates the supports the probiotics as stabilizers. And probiotics by definitions are live microorganisms which should have health benefit on the host. And symbiotics is a combination of the two. Enzobiotics, I told you, is our concept where we combine the proteolytic enzyme with these symbiotics. Now, symbiotic, does it have a role? In a preclinical trial that our group did, we looked at the mouse and induced the ESRD by giving gentamicin IP. And we looked at what is the dose that is required to get a benefit out of it. Now, as we all know that it is a dose and strain specific. So when we looked at the various blends that we use, blend 1, blend 2, and blend 3. See, if you look at the blend 2, which was beneficial, I'll show you. It is the equal distribution of the acidophilus and the longum, okay, bifidobacterium longum. And when you look at what happens to the histology of this, the blend 1 shows the damage to the tubules. But look what happens to the blend 2. So blend 2 shows preservation of the tubules, okay, on histology. And blend 3 shows again there is a destruction of the tubules. So basically what it is saying is Just giving a probiotic will not help. It should be strain specific, it should be dose specific to get a benefit in patients with CKD. So similarly, when we look at the hematological outcomes of this study, we found that in the rat, the blend 2, which was showing a benefit in histology, also showed benefit as far as the creatinine levels and the BUN levels were concerned. My first clinical experience of use of probiotics was almost 10 years back when I used it for my patients with Chiral disease. This patient had very severe form of Chiral throughout the body. He was taken all kinds of treatment with dermatologists and physicians, and he was to a verge where he was in a mental breakdown because he could not lie down. The back also was studded with these chiral lesions. So I gave the probiotics for a period of 3 weeks and see the lesions, what happens in 3 weeks. Okay, one of the major causes for this chiral disease is inflammation. So somehow with this animal study and this, I was little convinced that probiotics are working. So then I looked into other studies. If you look at the first of the study, the Ranganathan group published, 43 patients they looked at 30 billion CFUs 3 times a day for a period of 6 months. There was some benefit, but it was not statistically significant as far as the reduction in the creatinine was concerned, but quality of life improved. The same group looked at dose escalation with first month at 30 billion TID, second 2 months of 60 billion TID, and 3 months of 90 billion TID. So totally again 6 months. When they increased the dose, they found that the creatinine was showing a significant decrease. There was an improvement in the hemoglobin, and the quality of life was improving. And then this is the study by Megan Rose, which looked at the protein-bound uremic toxins with the use of symbiotics. And she found that there is a reduction in the peak crusyl sulfate, but indoxyl sulfate, though there is a reduction, it is not very significant decrease. So with this, we went on to do our study, which was the first Indian study looking at the inflammatory status and its reduction with use of probiotic. I used stage 5D patients who were on dialysis twice a week and were not doing well. So what was our finding? We found that inflammatory markers like CRP, IL-6 and TNF decreased in 40 to 60% of the patients. It clearly states that not all the patients will benefit, around 60% of your patients will benefit, and if they benefit, the degree of reduction was very significant and p-value was significant. So this was the first Indian trial established the efficacy of symbiotics in reduction of inflammatory markers. Then we wanted to know what is the role of this proteolytics. Actually, the proteolytics, these proteolytics actually I'm talking about was being used in US for building the muscles for athletes. So we got it and we said, why don't we use it for our patients who are usually low in albumin and are usually protein energy malnourished. So we used, this study was taken up by Dr. Vishal Singh in Command Hospital, Bangalore, where he used this proteolytic enzyme in these patients who are on CAPD, and he looked it for almost a follow-up of around 1 year, and he found that there was a significant improvement in the albumin turnover. So with this, we tried to create a concept of enzobiotic that will correct both the protein metabolism disorder which is there as well as the correct the dysbiosis. But though the concept looks great, but it was not easy because the stability of the combination was doubtful. And the gut pH was acting as a barrier. And strains may be resistant to enzyme, but they have to be effective also. So we needed an animal study. We went ahead and did the animal study. Now we divided the rats, 12 in each group, totally 7 groups. First 4 groups were control. The 4th group was the gentamicin group. And if you look at the 5th group, it received the symbiotic, that is a probiotic. The 6th group received the enzyme. The 7th group was the enzobiotic group. So here I am showing you what is happening there. So if you look the group which was a control only for the enzyme, the protein has increased. So that means the proteolytic enzyme is working. Now if you look at this group 6, where we have used only enzyme with following end-stage renal disease because use of gentamicin, again you see that compared to this group where only gentamicin is used, the protein assimilation is better. And at the same time, you look at the creatinine compared to the gentamicin group and the other groups, it is better. So probably it was giving us a hint that control of the protein metabolism may be one step where we can reduce the progression of the CKD. But look at this where we have used enzobiotic, that is symbiotic plus enzyme. The creatinine almost remained normal, and there is a better level of proteins in these patients. Now similarly, if you look at the histopathology, this is the one I am interested in, the enzobiotic. The histopathology was literally normal, and there were few areas where it showed regeneration. So with this report in hand, we went ahead with the phase 3 trial, and it was called as EETOX. And the registration was done, CTRI registered, and we followed all the Helsinki protocols. The informed consent was taken from the patient who were above 18 years, and it was a 5-center trial, and it is a multi-center, equally distributed throughout India. This I did because, the previous study which we did, it was a single center, so acceptance was low. And we had 85 patients who came into the study. It was a double-blind and a randomized trial. Double-blind means I am blinded to what treatment I am going to give to the two groups. And a third-party lab, that is SRL in Bombay, was used as a center which will do the test for us. So the enzobiotic had these doses of probiotic in that, and proteolytic enzyme activity was around 3.55 lakhs units. And one thing what is very important is the strain that we used is specific, acid, bile, and antibiotic resistant. This is the schema of the study. So first, there were 34 variables that the patient were looked into once they consented to it. Then we also checked for peak resol sulfate and indoxyl sulfate. We also did SF36 scoring for this patient to see the quality of life. So at here the screening was done. At visit 1 baseline, they received the tablets, and it was made sure that both the enzobiotic as well as the placebo, the looks of it, the foil, the cover of it, everything looks the same. And we had a second visit at 45 days, that is halfway down the study, to make sure that all the patients were taken the medications correctly. And in between also phone calls were made every week to find out whether they are adhering to the protocols or not. So day 3 is the day 90, that is the visit 3, where we again did all the variables analysis again to compare. So if you look at the study recruitment and attrition statistics, totally 85 patients were in the study, but in the end we had 50 patients who completed as per our needs. Looks lot of attrition, but we wanted to make sure that the statistics is strong. So what happens, even if there is a logistic delay, we had given 48 hours it should reach. If it is more than that, we eliminated. The patients who had no extremes, very good response or very bad response, were eliminated from the study, and protocol violations were eliminated. Most important is that for the 90-day, we had plus or minus 7 days in the protocol. Anyone who came beyond 97 days were eliminated. And even when we were collecting the data, if in the final analysis, if even one data is missing, like urine routine, they were eliminated from the analysis. So if you are talking about statistical analysis for toxin evaluation, we did F ratio. The mean of the levels at day 0 and day 90 were compared for each of the group. And we also looked at the improvement ratio of day 90 to day 0 for individual patients in each of the group. And as we evaluated, we did the multivariate analysis, we found that we could define the risk of progression of CKD, which was put at PCS values of more than 20 grams per ml and IS values of more than 20,000 nanograms per ml. And quality of life assessment with Cronbach's alpha for consistency response and adversity ratios were analyzed. So what do we see in the PCS and the IS? If you look at the PCS, placebo showed an increase by 12% from the baseline, day 0 to day 90. And when you look at the enzobiotic group, there was a decrease by 31%. So similar trend was seen for IS, though not as significant as PCS, but definitely we showed that there is a decrease by 7% in the enzobiotic group compared to 8% increase in the placebo group. So when you look at the risk of progression using all these factors, as I said, the definition was set for day 90, and this is what we see. If you are using with respect to IS levels, After 90 days, placebo showed 35% risk of progression, whereas enzobiotic showed 24% risk of progression. And with respect to peak resol, 53% in the placebo group had the chances of progression compared to 33% in the enzobiotic group. Now, for the quality of life assessment, we looked at adverse ratios. Now, see, there is a lot of difficulty when you are analyzing quality of life. There are few questions where you cannot give a quantification. How is your emotional status? For example, question. But there are also questions where it is easy to quantify how long you could walk. So, and there are questions where you have low levels and you cannot clearly identify. So for that, adversity ratio was done. And when we did the adversity ratio, we found that 4 out of the 7 components shows a lower adversity ratio for the enzobiotic group. So, and if you look at the significant improvement in those questions which has higher the better value. And daily activity initiation, adversity reduced from 57% to 47%, emotional problem from 52% to 31%, general health from 49 to 19%. We also looked at can we derive an equation, because PCS and IS cannot be measured at present in India, and even if we do it, it is very costly. Can we derive an equation? So we looked at various variables, and we came that 82% of this variation was explained by 11 principal variables, 9 were negative, 2 were positive variables. And when we looked at this graph for PCS alone, you will find that these variables which are sensitive were uric acid and platelet count. Similarly, you had urea creatinine in this group.
Dr. Sanjay, can you conclude?
Yeah. So we developed this prediction equation. So if you put this equation, you will get the values. So, but it needs to be validated at a later stage. Similarly, prediction equation for indoxyl sulfate was done. So to conclude, we have one answer where we can control the inflammation and the fibrosis, probably using the enzobiotic. And to put it in summary, enzobiotic is a new kid in block, reduces the protein-bound uremic tractions, reduces worsening of GFR, risk of progression of CKD to higher stages is reduced. It improves the quality of life, and EETOX study has given us the equation which needs to be validated. So this is our journey. We were, this study was nominated for Jason's Best Research Paper 2021, but we could not get it because there is one clause that all the investigators should be less than 45 years of age, and we were above that. Thank you.
Thank you, Sanjay, for that intriguing talk. So before we open the floor for discussion, I have a question for you. You have nicely described the gut-kidney crosstalk and the role of enzobiotics. So the preclinical trials have shown that when there's a transplantation of the fecal material from a mouse model of CKD to normal mouse, so they could demonstrate the uremic toxins in that. So can the reverse way, so the non-CKD mouse models to the normal mouse, can it alter the gut microbiota and change the dysbiotic gut to a symbiotic gut?
You are saying that you will take the fecal from the normal mouse to the CKD.
Mouse to the
CKD.
Yeah.
So I am not aware of any study that they have done looking at.
Because in the preclinical trials, the bacteroids, colonization of the bacteroids in the mouse model, they have shown that the albuminuria has decreased. So in the same way.
See, basically, now if you look at the progression of the CKD, this is one of the factors, the dysbiosis. Now, I showed you 3 arms for the management, out of which one probably if you are doing the fecal, you can say transplantation, you are doing, it improves the dysbiosis, but what about the other factors? So, it is a combined effect that we are seeing. Definitely, there are studies which show that once you do the fecal exchange, the improvement in some of the parameters of the CKD happens, but reversal of the CKD has not been shown.
Okay. So another question. You have used this enzobiotics with a combination of pre-probiotics and proteolytic enzymes. So any particular brands available at present in India, and what will be the cost of treatment, and how early we should start this in CKD patients?
In our study, we have used it for stage 3, 4, 5. And predominant of them were in the stage 4 and 5 where the damage has already set in and it is progressed.
Yeah,
Talking of enzobiotics, it has already been, it is going to be launched in next 1 or 2 days. It is called as EETOX. So it has not yet been launched. So it is pre-launch trials which has been done.
Okay, thank you. What will be the cost, approximate cost per month?
See, the dosage requirement is 2 tabs per day. So presently, I think the MRP that they have finalized is around 130 rupees per tablet. So it will be around 250 rupees approximately per day.
Thank you. So now the floor is open for discussion.
Sanjay, congratulations. One comment, generally in a clinical trial, you actually take intention to treat analysis. So I think by eliminating so many patients, that may not be the usual trend. So I would suggest that you do both intention to treat analysis and also on treatment analysis, where you're excluding all the people who did not follow the protocol. Secondly, you said it's going to be launched. Now, what is the, is it like, does it require a DCGI approval, or if so, on what basis it is approved? Yeah.
So this is based on the trial which we have put forward. The DCGI is already approved. There is a patent available and 52 countries have given us the intellectual property rights ready for sale.
No. I'm saying the DCGI approval is based on the changes in the PCS and indoxyl sulfate, which are basically intermediary molecules of interest. But have you seen, at least in animal studies or anywhere, the GFR decline is stabilized or GFR improves, any such data? And also, are you planning to follow these 3-month study into a longer study?
No, now once the drug is launched, we are planning for a post-marketing survey with around 2,000 patients. Now, this doesn't come under the drug yet. It is coming under the supplements. So supplements, it is clearly if the chair allows me, see why we are not seeing the response with probiotics. That we should understand, because it is dose specific and strain specific. And I can vouch, all the companies who are selling their probiotics, except 2 brands, rest all have not been authorized for sale for CKD. So, and if you define a probiotic, if you go by WHO definition, it says that it should show a beneficial effect on the individual who is taking it. All these companies, have they shown beneficial effect? I don't think anyone has done any study. I know of only 2 brands which has done that. So, and these 2 brands claim it on the box that it is to be taken by CKD and which has been approved for the use in CKD. Rest all brands have not been used. One more thing I want to put it here is, you will find that when many of these companies are using spores. You have to understand that spores are resistant even to 100, 120 degree temperatures. And they usually stay back in the gut. And there are enough studies to say if you should not use spores for more than 7 days, and you continue to use it in your ICUs for your loose motions and other things, there are very good chances that it will lead to gram-negative sepsis. So this has to be kept in mind. So when you are prescribing probiotics for CKD.
I think I thank the organizers. Thank you, Sanjay, for the new kid in the block, new therapy. And with this, we conclude this session. Thank you.
Thank you, Speaker and Chairpersons. Now I request both the Chairpersons to honor our Speaker, Dr. Sanjay Srinivas. And I request Dr. Palni Ravichandran, sir, to honor the Chairpersons.